Hello everyone, my name's Brian and welcome to my presentation on bipolar disorder. This is a condition that affects 2.8% of the US population per year, or 8 million adults. 2.6% of that population will have severe impairment. There's similar rates in both the sexes, but a slightly higher rate in women, and 4.4% of the US population will experience this condition at some point in their lives. As you can see on this graph here, there's also been a bit of a paradigm shift in the way this condition is viewed. In the past, many people who were considered to only have depression are now being seen as having some sort of bipolar spectrum disorder. And here you can see are some of the risk factors for this condition. The first one is this idea called stress sensitization. This is a concept of when a person experiences chronic stress and sort of becomes overloaded by it. They begin to become very sensitive to any type of stress. Even small stressors can cause a very big response in them. The next one is the serotonin S variant. Now this is a variant of the gene that codes for the transporter for serotonin. This variant is not as efficient in its job of transporting serotonin and will cause protracted responses to emotions, particularly negative ones such as fear and anxiety. They're saying that there's a possible link between toxoplasmosis exposure while in utero and developing this condition. Of course, significant life stressors are more likely to cause imbalances in a person and lead to this condition. Substance abuse will also cause imbalances in our natural neurotransmitters and will predispose us to this condition. Some individuals who have depression or are in a depressed phase and may not know they're bipolar and start taking antidepressants may be catapulted into mania and have a manic phase. Lastly, there's also a possible link to inflammatory conditions and this condition. In particular, there's a pretty strong connection between IBS and bipolar disorder. So how can we expect the bipolar patient to present? I think most of us will automatically think of a bipolar person as going through significant mood swings, but in fact, most of the time we're going to initially see these patients in their depressed phase. That's likely due to the whole idea that when they're in mania, it often feels good to them and they don't feel the need to seek out care, but when they're in the, that depressed phase, they feel awful and they might be more likely to seek out care. Of course, we're going to see the high highs and the low lows, but there's also like a sort of lesser high called hypomania that we might see in some patients, and a lesser low called dysthymia that we might see as well. Bipolar is the most severe form, and cyclothymic disorder is the most mild form. Now, this is a condition that's going to affect multiple brain structures, but the most pronounced ones that we're going to see affected are the amygdala and the frontal cortex, which are both involved in emotional processing and executive functioning. There's going to be dysfunctions in the way that neuronal cells are able to use energy. There's going to be increases in inflammation and oxidative stress in these patients. There's going to be abnormalities, of course, in the signaling networks going on between neurons. And lastly, of course, the brain function of these patients, and anyone in general really, is constantly being impacted by whatever exposure in the environment that they're facing. Now, it's hypothesized that all three monoamine neurotransmitters are involved in this condition. We thought of this condition as sort of like an imbalance between these neurotransmitters. Like in depression, there's a diminished amount, and in mania, there's an excessive amount of these neurotransmitters. But in recent times, we're beginning to discover it's more of a sort of out-of-tune communication system between neurons that's causing a lot of these symptoms, more so than an imbalance in the neurotransmitters, but certainly the neurotransmitters do impact the functioning of these neurons. So for our treatment plan for patients with this condition, we're most often going to want to put them on some type of pharmacologic management, which is going to typically include a mood stabilizer like lithium, some form of an antipsychotic, and possibly an antidepressant. But again, we must be careful putting any bipolar patient on antidepressant therapy because it might cause activation and lead to mania. We're going to use some non-pharmacologic options as well, such as psychotherapy, cognitive behavioral therapy, that sort of thing. We're going to want to promote lifestyle changes for them and, you know, have them adopt healthy lifestyle habits like getting enough sleep, eating healthy, and getting exercise. We're going to want them to find ways to manage stress and try to reduce the amount of stress in their lives. And lastly, we're going to educate them on this condition. So for our patient education, we're going to want to include information about their condition. We're going to want to include both the patient and their caregivers or their spouse or anyone who spends most time around the patient about all this stuff that they're expecting with their condition, the fact that they will probably have mood swings and that they need to stay on their medication therapy even when they begin to feel better. They need to be taught about signs and symptoms to watch out for and to report to their physician or their psychologist. And there needs to be stressed the need for a strong support system for the patient to manage all this. Lastly, they're going to need to be educated on their prognosis. And with patients in this condition, there's on average reduced life expectancy by about 12 to 14 years. And now the role of the Psych NP in this condition, of course, is going to begin with the clinical assessment of the patient. So we're going to want to assess the patient by their own words, you know, what they're experiencing, the symptoms they're having and all that. But we're also going to want to include somebody who knows the patient very well and is able to corroborate the story they're telling us and possibly report other symptoms that they're not reporting. Oftentimes, patients in this condition will underreport their mania symptoms because they don't notice them or they enjoy them or something like that. We're going to want to develop a treatment plan with the patient. We're going to want to, you know, take their individual goals and needs into account and incorporate that into our treatment plan as much as we can. We're going to choose the right medications for them that work for them and that are going to manage the symptoms that they're having. Well, if you're still with me, I thank you for taking the time to watch my brief synopsis on this complex condition. Again, my name's Brian Erb, and y'all have a great day.